Good afternoon, and thank you for joining us for our webinar on Governance Best Practices for Medical Groups, which will share insights from a national survey that was conducted of AMGA members. My name is Vicki Radcliffe, and I will be your moderator today. Before we get started with our presentation, I'm going to review a few basic instructions for our audience. First of all, if you have any issues getting online into this presentation, but if you're already called in, please call our Integrated Healthcare Strategies front desk, and they may be able to assist you. That number is 612-339-0919. Also, please be aware that all participant lines will be muted for the entire presentation in order to reduce noise and distractions down the line. At the end of our presentation, we will allow time for questions and answers. If you do have a question you want addressed at that time, you may type it in and we will read it off for you to be answered. To do so, simply click on the Q&A button on the menu bar at the top of your screen. Just go ahead and type and submit your question, and we'll do our best to make sure that it is answered. Now I'd like to turn it over to Ryan O'Connor to formally introduce today's topic and our speakers. Ryan is Vice President of Marketing and Membership for AMGA. Welcome, Ryan.
Thank you, Vicki, and welcome, everyone. A key component to medical group success is governance structure that sets the strategic direction for the organization, aligns physicians, and provides appropriate oversight of management, quality, and financial performance. In the fall of 2009, AMGA, along with Integrated Healthcare Strategies, undertook a collaborative survey of AMGA's member groups. The survey provided useful insights into factors that can facilitate great governance and hence great operational success of medical groups. Today's webinar will help gain new insights into the governance and leadership factors that will frustrate and facilitate higher performance among our nation's leading medical groups and other organized systems of care. Following the webinar, each participant will receive a copy of the recent report on governance patterns among AMGA member organizations. Leading our presentation today is Jim Rice, an Executive Vice President of the Governance, Leadership, and Executive Compensation Practice of Integrated Healthcare Strategies and Vice Chairman of the Governance Institute. He draws upon extensive experience in integrated system development, managed care, and HMOs. His experience also includes important work as a teacher, author, speaker, and consultant to physician groups, boards of directors, and ministries of health in over 30 countries. Also joining us today is Dr. Roger Gilbertson, President Emeritus of Medicare Health System, an integrated delivery system with over 400 physicians serving Fargo, North Dakota, and the surrounding areas. Dr. Gilbertson has served in medicine for 30 years and has built a strong community partnership with people across the region during his 17 years at the helm. So without further ado, I'd like to turn it over to Jim and Roger now. Jim?
Thank you, Ryan. Good afternoon and good day, everyone. We're delighted to have this opportunity to share some results of this survey with you and hopefully continue to stimulate a passion to inquire about how board work in this nation's large medical groups can be strengthened and enhanced. We're going to be, of course, acknowledging the importance of governance because of the pressure that is being placed on the groups across the nation, accountable care organizations, new demands for quality, new pressures driving toward bundled payments between groups and hospitals, the continuing challenge in groups that are multi-specialty on how to strengthen and enhance relationships between the specialties in the profession, and a number of others that are really going to give a high premium to the groups that can demonstrate not only good governance, but continuous governance enhancement. If you will look on slide 5, you'll see the flow that we're going to take today in this short webinar. We will share some conclusions with you for approximately 45 minutes and provide an opportunity for some questions and answers at the end. You'll see that we are going to look at two major areas of conclusions drawn from the survey: the challenges that boards of large medical groups are wrestling with in their governance arena, and also some of the new strategies that they're finding to be helpful to enhance the effectiveness and the efficiency of those that serve in the governance area. You'll see on slide 6 the two documents that we will be sending out to all the registered participants as well as, of course, the slides that Roger and I will be using. As we get ready to look at both the challenges that are facing medical groups as well as the strategies for enhanced governance, let's first base our understanding for all participants on the scope and nature of this survey. On slide 7, you'll see that we had in excess of 100 groups respond. A little bit over 11% were in large groups that had revenues in excess of $500 million. A large number were in the zone of $100 to $200 million of revenue. We received good participation from throughout the United States, high concentrations in the Midwest and Pacific areas, and a smaller participation from groups in the mountain states. We believe this is a fair representation of where the larger groups are located. On slide 9, you will see that in terms of the number of physicians in these groups that responded to this survey, a large concentration were over 150 members. We also look at the responses as the size of groups will vary, approximately an average of 11.8 members in these boards, and a few of the groups responding do have non-physicians. We'll comment on that a bit further later in the webinar. With respect to the perceptions of these respondents on the appropriateness of their group board's size, most are comfortable. However, about 13% or so believe that their group is too large. If we look at the meeting frequency, this is an area that we will explore a little further in this webinar. The average number of meetings is 13 and the median was 12. We are starting to find, when we interviewed some of the group leaders, that this is a persistent challenge. How often should boards be meeting? We will be commenting a bit later that there still are a large number of boards that, in my opinion and in my work with large groups, are meeting too frequently, to the point where it makes it too easy to drift into operational versus strategic challenges, and is, in some instances, bedeviling the management teams about how they can focus on their work compared to the board focusing on the more strategic and policy activities of the board. And you'll see on the bottom of slide 11, about 12% are believing that their boards are meeting too frequently. If we continue this quick glance at the profile of the respondents, most seemed quite positive about whether their boards are going to have the horsepower necessary to accomplish their governance and deal with their governance challenges in the future. Let's start moving into some of the observations shared with us in this survey, and then we will have an opportunity for interaction with the substantial number of people that have registered for this webinar. On slide 13, you'll see that some of the soft spots are identified in these 6 points. They're focused around how does the board continuously look at its own effectiveness, how does it look at the challenge of recruiting in talented new board members and then developing the type of orientation and capabilities that they need for high-performance governance. Also some challenges around the role of the board in successfully planning for and conducting the CEO performance review. When we had an opportunity to review some of these findings in December at the AMGA meeting in New Orleans, one of the hottest issues in the question and answer period there was how are boards going to be more successful looking at the interface of their chief executive and the board, particularly as it relates to performance planning and appraisal. It almost goes without saying on slide 14 that groups are growing rapidly, and the pressures in the marketplace in the United States are suggesting the need to band together and develop economies of scale, and the camaraderie and the collegiality between groups, particularly multi-specialty groups, is expected to continue for the several reasons, 8 of the most important cited by participants in this summary and this survey are concluding for you there on slide 14. The new pressure from the recent health reforms just enacted are likely to make more clear and more frustrating the drive toward bundled payments that you see in item number 8. But certainly, groups are expected to expand as a lever not just on patient quality and a superior patient experience, but to have leverage with these new insurance exchanges and the new changing payer landscape that we're all going to have to wrestle with. We see that on bundled payments on slide 15, a headline from the research into this arena by RAND, and also as we start looking at what does the board need to pay attention to, of course, the formation of successful groups is a challenge, and developing bold and cost-effective ways to govern these groups is not easy. There are new challenges about how to share decision-making, the new investments into IT, the continuing struggle to have short-term versus strategic are all important elements. Let's go through for the next couple of moments and a few slides looking at the challenges that we identified. The survey identified 10 key challenges facing boards and also 10 important strategies. We will summarize all of those. I will take a moment to share with you the highlights of these top 10 challenges, and then I'm going to ask Roger Gilbertson for some of his commentary on his work at Merit Care and also his work throughout the nation talking with his colleagues as leaders of large medical groups, what he sees to be the challenges. And we'll also ask Roger for his insights on some strategies that should prove productive for us as we go forward. So on slide 18, we have the first 2 key obstacles. One is a continuing nagging frustration on how to keep the board focused on the strategic imperatives and opportunities facing the group, especially a challenge when there is this growing squeeze on the financial and payment arrangements, new challenges for electronic medical records, and the whole physician-hospital alignment, which is going to be important. Many groups, obviously, inside of the AMG membership have their own hospitals, and so this challenge is not that much easier for them, but we expect to see more discussion and debate about this going forward. The second of 10, again, looks at the challenge of staying strategic and avoiding getting drawn into operational and day-to-day affairs of the group. We all know this is easy to say but difficult to do. We have seen, however, that the more frequently that boards meet, the more likely it is that they will get into operational issues rather than strategic. On slide 19, 2 additional challenges are the need to have the board focus on the strategic vision for the group. How would they like the board to look and behave in the summer of the year 2020, and have intelligent and innovative conversations with the board and with the physician shareholders about what are the most practical ways to get from where we are today to that desired future state or the vision of the group. I would say that in interviewing after the survey a number of group leaders across the nation, all are trying to find bold new ways to establish visioning exercises and visioning conversations not only within the board and within the management team, but with the full cadre of physician shareholders. Some are starting to use web-based tools to enable this. The fourth challenge is a lack of time. That's the perennial challenge. When we did this study in 2005 with AMGA members, this was in the top 5 challenges, as it always seems to be. On slide 20, we identify challenges 5 and 6, the need for boards of medical groups to have evidence-based decisions as they develop their policies, and to keep in this process of finding facts upon which to base their policies and their strategies, to keep it patient-focused. There is still a fair amount of emotional agenda setting and conversations in far too many medical group boards. The sixth one is a challenge on putting aside or investing in intentional physician leadership development. Even the large and longer established groups find it a challenge to not only get the time from physicians to migrate into leadership roles, but to back up that commitment with investments into physician leadership training and even short-term sabbaticals in other groups or in other healthcare delivery organizations. The last 4 challenges appear on slide 21, the complexity and speed of change, a lack of clear plans for board member selection and succession planning, the irony of, I would guess, the paradox of not communicating enough and trying to communicate so much that you become too democratic and bog the group down in trying to develop their effective and efficient governance and strategy moves. It's the perennial communication challenge, isn't it, between physicians and their board and their executive team. And then the final frustration that we saw explained and defined in the survey is the need to really get talent into the board to focus on what's really important. Now, we know that, Roger, you have wrestled with a lot of these similar challenges. I wonder if you found any surprises in the survey results, and more importantly, what you found to be 2 or 3 of the most important challenges in your work developing and guiding Merit Care prior to its recent merger with the Sanford Health System.
Yes, thank you very much, Jim, and I think you gave an excellent outline of governance as we see it, the evolution of it, and as we see it today, and in many ways. And my involvement in governance has been something that I've thought to be extremely important. Now, Merit Care has been an integrated delivery system for a long time, and particularly in the last 17 years with a large physician group of 450 or so and a 600-bed tertiary hospital covering a large geographic area in order to get the population base for that kind of an organization complicates the issues of governance. But what I would say relating to where we have been in this evolutionary process of governance, I would say a couple important things. And one is that governance is not a static process. Governance is an evolutionary process and must change with the times and the complexities of the organization. There's certain things about governance, like a constitution, that are always lasting, and that's important. Example of that being the separation of governance and management and so on. But that's an important component, and as I see what's on the horizon and has been on the horizon for some time, only adds to the challenges of governance with the added complexity of healthcare and the healthcare organizations, as you aptly outlined, the coming together of hospitals and physicians in groups and how those integrated systems function. I see only major challenges in the complexities of those kinds of organizations, and hence that will require more sophisticated governance, as you point out, and And there'll be many things about that that are important. I'm a strong believer in physician involvement in governance, not only from the integrated system, from a system standpoint, but also from the governance of large medical groups. And I think that the critical thing with that process is education and training physicians, as well as some lay people, many lay people, in what this means. What is really governance about? And in the long time that I've been involved with this and other things in the community, I'm struck by the lack of information or lack of really understanding about governance as a whole. And so I think this is going to become a major challenge. What we have done is, over a long period of time, over 10 years now, had a continuous process of educating and training of physicians in both leadership and the concept of governance. I think it's where people have major challenges is when they put physicians in these roles with no training or understanding of it, and they are not understanding about what their what I call their RREs, roles, responsibilities, and expectations about governance and leadership. That's where the trouble is, and I think that they're busy. Physicians are all busy, and it's hard to establish that, but I think that will be increasingly critical to invest in physician leaders and others in concert with executives and others that will be important in understanding about governance. And from a lay person's standpoint, where the lay people are, we can no longer afford to have lay people coming on the board and taking 2 or 3 years to to understand the complexities of healthcare governance and its delivery. So we need to spend a great deal of time educating and training those people as well to understand, so they can use their great talent that they have in helping us decide what is the best strategy for the organization in this complex environment. So that's sort of a short overview, but I think education and training of physicians and how that might work is to the advantage of the organization is certainly critical. It has certainly been so in the organization that I've been involved with.
Thank you, Roger. I particularly enjoyed your RREs, roles, responsibilities, and expectations, both for physicians serving on the board as well as the lay community leaders that may be invited in. I think that's wise counsel to focus on that, and I do see across the country that that is a persistent challenge of how to develop that clarity and to continuously educate and orient and develop that. In a few minutes, when we talk about some strategies, I'll want to see and have you share some of the experiences you've had on trying to develop board mentors and even some of the structures that you were putting in place at Meritcare. Thank you again, Roger. Let's move into a discussion now of the strategies that came from the survey. We found 10 key strategies, but a backdrop for those shows on slide 24. We have here a list of about 12 key items. I will not bore the participants by reading these, but encourage you to look at the final report that is sent out to you at the close of this webinar. And by looking at the benefits of laboring in the vineyard to have high-quality governance as a means toward a much more vital and high-performing group. And that means it's useful to be reminded of the benefits of the group. Many of the participants in this webinar are so close to it that sometimes you fail to take a deep breath, step back from your day-to-day work as leaders or members of the board, and say, and in fact have a conversation with your physician shareholders. Why in the dickens do we have a group? What are the benefits of going through this challenging time of establishing and fine-tuning and enhancing the group structure and the governance model that you have? It ranges from enhancing the quality of patient care to smarter strategic planning, a capacity or improved probability for better facilities and technologies, and of course recruiting in the physician talent that you need. All of these are among these top 12 benefits that the survey identified from having groups, and therefore the need to have smart governance for those groups. We have on slide 25 identified 6 important strategies. We share these quantitative numbers with you, and in a moment I will go through 10 qualitative dimensions that the interviews with participants in the survey teased out further depth of what can be done. And so improving the systems for quality and patient safety are some of the strategic agenda items that the participants believe are going to be on the plates of boards over the next couple of years. Improving communication with physician colleagues. In a moment, Roger, I'm going to warn you, I want to ask a question about how does the governance work in merit care, and probably in the new, much larger, expanded Sanford Health and Merit Care, this continuing challenge of how does the board communicate with physicians and invite input from physicians. I'm working with a group in California right now where that's a continuing challenge, is how do you improve collegial relationships and communications between boards and their physician colleagues. If the participants in the webinar will look at the 4th bullet point, I wanted to call attention to this. On a scale of 1 to 5, an average of 3.8 of the respondents thought it's essential to assure that the board agendas are 80% focused on future strategic challenges and less on operational. Again, it's one of these easy to observe conclusions that we see in this survey, but as we all know, it's a bigger challenge on the street and on the ground to make that happen. One of the things that we'll talk about in a moment that I've found useful with large physician boards is to think of an 18-month calendar where the board, as well as physician shareholders, see that over the course of the 18 months, there are themed meetings, and the agendas for those meetings sometimes take a different flavor. There's some speakers. There's some patient cases that are discussed. There are strategic visioning opportunities. And only, I have found, when you think longer term for the work of the board committees and the work of the board in its meetings, and will you improve the probability, but no guarantees, but improved probability that the agendas start migrating more to the strategic than the operational. Trust building is a big challenge, and it's a desire from the respondents to the survey to build that through enhanced communication. We'll talk more about that in a moment. So if we look at enhancing group governance, what are the 10 most important actions that came out of this survey? The first 4 of the 10 show on slide 26. You look here at the point that Roger was making, that great board work doesn't just happen. You have to be intentionally developing it, planning it, and investing in the training and the information for great board work. The second challenge is to be clear about performance expectations. If you don't know who you are and where you're going, as the old saying that we've heard so many times, it doesn't make too much difference of the path you're going to try and follow. So the second important strategy is to look at clearer performance expectations. Far too many boards of medical groups do not have a simple 1- or 2-page job description for their board members. They do not participate in annual performance reviews of their board members or the board chairs, and on a going forward basis, this will have to be a new strategy that receives more attention. Also, you'll see in item 2 that many boards are starting to experiment with a board eyes-only website, parts of which are only available to the board and parts of which are available to all physician shareholders. But it's in this board portal, if you will, that board members can find copies of their strategic plan, the financial ratios, the quality metrics, the competitive position they find themselves, easy to reach and to access 24/7 information that they can use for better governance. The third key strategy of the 10 we found is continuously focus on two-way communications and to use new techniques. Some boards are starting to experiment over the last 6 months in applying social networking within their groups, the Twitters, the Facebooks for their groups and their boards. But the key underlying driving force is to enhance communications. And the expression that I find very helpful is learning to listen and listening to learn. That kind of mentality is so important with the complications that groups and their boards are going to deal with. The other is the focus on strategic challenges, looking out the windshield, not in the rear view mirror. And this is where boards are finding before they step into their fiscal year, the board has a conversation with their executive team about their dashboards. Now, I have seen some of the people that have registered for this webinar. Many come from sophisticated groups and are already starting to use dashboards, but I hope that you will continually migrate to make those digital dashboards so that they can be refreshed and have that red, yellow, green lights, if you will, on when the short collection of performance metrics are being well achieved. They're in the green zone, and you don't gum to death with a lot of questions those performance metrics, but if they're yellow or red, you heighten the focus and the question activities. The fifth and sixth of the top 10 strategies for better board work you see shown on slide 27. The idea of being more intentional about competency-based board work. The strategic needs of the marketplace in which your group is working will dictate the strategic imperatives in your business plan. Those strategic imperatives should identify the strategic competencies that you want represented by the people sitting around the board table. And so intentionally identifying those profiles of ideal board members, looking for the knowledge and skills and attitudes that are necessary, looking at spicing up the board discussions by bringing non-physicians into the board, having job descriptions, and examining not just the compensation for those serving on boards, which is getting more attention now, but looking at a more intentional self-assessment of how well each person believes they are doing and their colleagues are doing on the board. The sixth is an interesting strategy where several people took the time to type in that they are borrowing ideas from other industries, other healthcare corporations, about a more disciplined governance model. It's not sufficient in this highly charged, very high-pressure cooker need for accountability and transparency on your board work to go along with the collegial or the fraternal kind of governance model. It doesn't mean that you have to be crass and rigid and businesslike in what you do on the board, but it does speak to the need to having more discipline, more formality, and more structure as you look at building your board agendas and looking at that relationship that Roger cited on the relationship between the board, which should generally focus into the strategic and policy arena, and management, which should, of course, be a partner on the strategic arena, but is very much focused on the operations. We're just about done with the last 4 of these strategies for enhanced governance that came from the survey. I'm going to ask Roger to make some of his comments about what he sees over the next 2 and 3 years to be important strategies for board leaders and group leaders to take into consideration to look at continuous governance enhancement. But let's look at these last 4, go to Roger, and then we would like to have some opportunity to interact with our colleagues that have registered for the webinar to see what questions they may want to put to Roger and myself. So on slide 28, we see that the board decision-making culture should have a low tolerance for disruptive behavior. When I started working with medical groups about 10 years ago, it was not uncommon, not literally, of course, to have fist fights, but to have board meetings devolve to disruptive issues and a lack of collegiality in looking at strategic plans and performance targets and monitoring performance. Thankfully, over the past decade, there has been substantial improvement in the quality and the scope and nature of the dialogue that occurs in board meetings and between the board and the group itself. But it's best if you have an explicit style or culture of how you choose to govern, and that is captured in the policies and procedures of the board and is commented on and reflected on in the annual board self-assessment of how well it is doing in its governance decision-making. The eighth strategy that surfaced from the survey is to look more creatively at the board agendas to make sure all of us that have devoted so much of our careers to health care and to the delivery of health services, if we can keep a large part of the conversations at the board around the needs of the patient and how does patient-centered discussion of quality and safety, as well as obviously the financial dimensions and fiduciary responsibilities of the group, finding that balance can really enliven the conversation and rekindle a sense of enthusiasm for board members willing to serve in the governance process. The ninth of the top 10 is to try and have coaching among yourselves and occasionally with outside board members and outside advisors to look at how you can enhance the quality of the discussions, not just listening to reports. I would offer this advice. If you look at your agendas for your board meetings over the last 18 months and you find the vast majority of your board agendas go like this: report from CEO, report from CFO, report from Chief Medical Officer on quality, or report from committees, and then when you're exhausted and you have only 10 or 15 minutes left for some high-quality discussion of strategic issues and challenges and opportunities, that lockstep movement toward an agenda, if you have that for every one of the meetings you have throughout a year, I would say that's an unhealthy agenda flow. You've got to experiment and have 2 or 3 meetings a year where you completely flip those agendas and bring in some speakers and discuss some strategic challenges that you're going to be orienting to in the future to make sure the quality of conversation goes up, and to have a board chair that has a style and a comfort with asking for, at the opening of the meeting, if there are new agenda items, to migrate toward consent agenda items, to ask at the end of the meeting if anyone has further questions, or to provide one last opportunity to offer suggestions of topics for the subsequent board meeting. All of these can enrich the quality of the dialogue and the conversation in board meetings. And then finally, we need to look at item 10 on slide 28, which is to really make sure that all, or at least a large portion of the board discussions are focused on what is best for the long-term vitality of the group and the patients and the communities that you exist to serve. Now, Roger has been working on continuous strategies to look at ways to enhance both how board members feel their time and talent is well used. I want to give him an opportunity as he looks out into the future. Over the next 2 to 3 years, Roger, what would you sense to be a couple of the most important strategies or approaches or mindsets that boards of large medical groups would be wise to take into consideration in their journey for continuous board improvement and continuous governance enhancement? After Roger shares some observations with us, let's move to some questions with our colleagues that have registered for the webinar. Roger, what do you think about the future? Are there a couple of things that you found helpful to improve improve board work going forward, and what would you share with our colleagues in this webinar?
Yes. First of all, I would like to congratulate Jim on what he covered here, because it was just repeating a lot in my head what I think are absolutely the critical things. Partnership with each other on the board, as well as the CEO, the relationships of trust within a board, the REs that I mentioned, the education, intelligence. Where do board members get their intelligence? So he mentioned the balanced scorecard, or he mentioned dashboards, and I think those things are important. And before I get into what I see the challenge in the future for a second here, is that I think what has been done, where we finally took the bull by the horns and said we are not going to spend all our time on finance and reports and so forth. So the consent agenda has been used very, very extensively, and all these perfunctory reports that have to go to the boards, that can all be done with a consent agenda to try to get the board thinking strategically, and that's a critical component, and actually board members like that. In transitioning to the next 2 or 3 years, I think I plan my retirement at the right time, because this is going to be tough times. And I would just point out to the people on this conference that one of the big challenges is the reduction in healthcare costs and all the challenges of delivery that are coming upon the additional 30 or 40 million people coming on this, and the great shortage of physicians. So we're driving tremendous change into an industry that is going to have a great deal of shortages relative to the physician group, and that's going to be a major challenge. So one of the strategic issues for governance will be, how will we strategically deal with the issues of chronic disease management, primary care, when there are not going to be enough primary care physicians? How will we use mid-levels? How will mid-levels be used? Can they be used for management of chronic disease? And I think there are some very good models that have to be adapted. Otherwise, there's going to be chaos. The other major thing that I think from a sort of a cultural, political standpoint internally is the challenges that exist to this day between primary care and specialty care within these larger groups. There's conflict within those, and with the bundled payments and all, that's going to become increasingly challenging for governance. How do those issues become resolved? Now, what's been done at Medicare and Sanford and Medicare as well is a board of governors of physicians. And the board of governors, which is all physicians, with the president of the clinic and chairman of the board, all being all physicians, and they will have legal responsibility as well as operation or governance responsibility for the medical group. They will, of course, be subjected to the authority of the system board as a whole. But in general, this has been a very positive thing for physicians, because if for the first time they feel that decisions that they make and the input they have really does matter. And I think that's going to be a great advantage in dealing with some of these very thorny issues that are coming down the road that really, I think, are going to determine whether we're going to be successful or not.
I agree, Roger. And I just want to warn Ryan from the AMGA to give him an opportunity, if he has raised if he has a question or a comment, we'll give him an opportunity in just a moment as well. As we get ready to migrate to our question and answer period, I'm going to invite Vicki just to remind our participants about how they can register their questions with us. And I would share 9 buckets of responsibility that great boards of high-performing groups need to pay attention to. There are 3 fiduciary duties that boards of medical groups need to pay attention to. These 3 duties, duty of care, duty of obedience, duty of loyalty, drive toward the mission, the fundamental reason for being of the medical group, which is, of course, patient care, and as an important but secondary role to support the practice of medicine of your professionals that are coming together, banding together to enhance patient care and the profession itself. So you have 3 fiduciary duties and 6 key roles of a high-performing board of a medical group. One is to set strategic direction. The second is to have quality oversight. The third is to provide financial oversight for the group as it drives toward its mission. The fourth is oversight of management. The fifth is to look at its advocacy role out in the broader community, both with community, hospital leaders, and politicians. And then finally, a very important role that's often overlooked, it is the care and feeding of the governance process itself. Great boards of great medical groups continuously try to refine and enhance their governance processes, their governance structures and strategies and systems. So duty of care, duty of obedience, duty of loyalty, and these other 6 roles are important for high-performing boards going forward. We have about 15 minutes where we're going to see how many questions we can answer. Vicki, I know you often remind us that if we can't get to all of the questions, we will respond by email very quickly right after this webinar as well. So, Vicki, I'll ask you to make a comment again about how they can direct questions to us. And Ryan, I'd give you the opportunity, if you are interested, to make a comment or a question. I know that Ryan will also have a closing observation near the end of our time together. So, Vicki, how should they direct questions to us?
Thanks, Jim. You're right. We do have a few minutes. We'll take some questions. I'll review how you can do that. Even if we don't get to your question, we can see that it came in, and as Jim said, following the webinar, we'll get back to that participant with answers to their question, either via email or a call or whatnot. So again, to type in a question to have read off, please use the Q&A button on the top menu bar at the top of your screen. I'm going to go ahead and take the first question that we did have come in during your presentation. One moment here.
Ryan, before we address the questions, do you have a comment or a question yourself as we start to move into the question and answer period? I know that it's not necessary, but just want to give you that opportunity.
I would just add the importance of governance is something that's going to take on additional importance as groups look at accountable care organizations and how they can position and structure their organizations to take advantage of that. We see governance as one of the core tenets of that, along with aligned incentives and coordinated care and organizational structure. But the governance and having especially a strong physician role in the governance model of an ACO is going to be critically important for the success of those entities.
I agree. That's wise counsel. Okay, Vicki, what do we have for questions?
First question, Jim, is we have often talked about trying to have fewer board meetings, but it is difficult. How are other groups getting their work done with fewer meetings?
It's a challenging question. I'll make an attempt at that, and Roger, if you have an observation of how can you get the work done and do it well with fewer meetings. You will recall, those of you on this webinar, that the average group is still meeting monthly. Some have as high a meeting as twice a month. I would go berserk if I had to have twice a month board meetings, but each group has its own style. I'll share what I've seen to be some of the ways to experiment, because many of the boards are trying to get to a sense of confidence with themselves, confidence and trust with their management, and confidence and trust that's shared with the physician shareholders to go to every other month board meetings. This is only possible if you have trust among all of those governance stakeholders. The kinds of things that improve the probability of reducing the number of meetings are, I guess, the following. Better and more transparent board information. The board can still get monthly board packets that describe financial performance, volume performance, productivity, quality, morale of the workforce, morale of the physicians. There should be an opportunity for that information to be digestible. High-performing boards are not only using dashboards, but they are using literal dashboards that look like the dials of a high-powered sports car, where you have you reach agreement on the key metrics, and you look at how to graphically summarize that so board members that are busy physicians and lay and community leaders can take a rapid glance and tell at a glance what is happening in terms of performance. Also, it helps to have this 18-month calendar that I mentioned, where board members and their physician shareholders know that over the course of that rolling 18-month calendar, all the key issues will be addressed. You don't have to address every single issue on every single board meeting, but too many of the boards that I've seen with on large multi-specialty groups devolved into trying to talk about everything at every meeting, and they not only meet too frequently, but the meetings start to end, or I'm sure they feel like they never seem to end, and they start having 2- and 3- and 4-hour meetings, and I think that will prove to be counterproductive in this highly charged area that Roger just acknowledged. Roger, I'll give you a chance. Have you seen any particular silver bullets on how to get the board work done with fewer meetings?
A couple of things. One is is electronically. I think they have a secure website where you can access board members on a continuous basis. They can have access to the balanced scorecard or dashboard or whatever you're using, and they're color coded, as you pointed out earlier, Jim, so they can determine the position of the organization at any given time. We have changed over the years many times. We were once a month, and then we went to 6 times a year, and then we went to 4 times a year. But when you do that, then we have stronger committee meetings. For example, the Finance Committee does a lot more work by itself, and the Quality Committee does more work. And what we found at the board meetings is we spent about 15% perhaps or to 20% time on finance, and I would say 60 to 70% time on quality and other factors that involve the function of the organization, which are much more critical rather in determining how well the organization will do. So there's some of those, it's how they get their intelligence, make that more efficient, the use of the consent agenda, which is very important, determine what you really have to have the board approve. And do that largely, you can either do it electronically, and if the board all votes unanimously to approve it, that's all you need to do, or you can do it with a consent agenda at the board meeting. It's worked extremely well.
Good. I think those are very good observations. You just made me think of another chief executive of a medical group that said, you know, I think a great innovation with our board materials is colored tabs. I hope the participants in this webinar are a little more creative than just using colored tabs to spice up and enliven the information they have for faster and smarter decision making. Vicki, other questions?
Yep, we do have several questions. We'll try to take as many of these as we can. Next question we have up is, can you recommend some of the best board training tools that you have come across?
Yes, there's a growing body of information that can be made available for medical groups. They come from there's materials that are increasingly being developed within AMGA. Some of the participants have the advantage of getting some materials from the MGMA. There are materials that you can adapt from the nonprofit hospital sector. State hospital associations have board manuals and governance activities. There are resources available from state healthcare associations. There are a group of nonprofit organizations in Washington, D.C. called Board Source. The organization that I'm affiliated with, the Governance Institute, the consulting group that I'm affiliated with, Integrated Healthcare Strategies. A number of the large consulting groups are increasingly making available a portfolio of education materials, streaming video that you can access. You can bring in speakers from local community colleges into your board meetings to help you do governance retreats and education. And the last comment I would make is most of the participants in this webinar network with each other. There's no reason why you can't once a year schedule a 90-minute conference call where you have sister groups call in together and swap stories about what's working and what isn't and how you're approaching education. Be creative on how you use social networking among some other groups and even within your group to continuously enrich and refresh the education that you're dealing with for board development. That's long-winded, but I hope that is useful.
Great.
Jim, let me just, could I just add one quick thing on that? Because I think a lot of CEOs and others, when they have some national people come in and very formidable governance people come in, Sarbanes-Oxley and all the other things, I've sat there many times and wondered if we have any rights at all to run our own company anymore, that you sort of get an idea that you have to have everything approved by the board. And so I would say that you need to understand that, but you need to also know really what do you have to do, and don't abdicate the responsibility of passing all these things through the board so that you inundate them with information that they don't need to have in order to supply good governance.
Okay. Be efficient as well as effective. That makes good sense.
Great. Thank you both. Next question, Jed asks, discussion at our board meetings sometimes evolve into clinical matters. Do you recommend a regular meeting for non-governance issues matters of a clinical nature?
Well, some of the large groups are experimenting, as Roger's identified, with a clinical council which really takes up and continuously monitors the 20 moments of truth of the patient experience. It has in-depth conversations about the quality and the safety of the patient interaction at your different delivery sites. It looks at technology trends and evolving science of medicine. And so I think many boards are developing some parallel education, conversation, and planning tracks for some of those clinical issues. But it would be a mistake if you segregated all the fun clinical stuff and patient items out of the work of the board, because then they're going to be defaulting back into the financial dimensions and the productivity and the service volumes, which are important. If you want to have it a little more interesting for great board members to stay with your governance model, you have to have an agenda that mixes and balances the clinical with business and with finance. But I do think we are starting to see some real innovative ways of taking a parallel track on some of these quality and safety and clinical dimensions. The one area that I'm surprised hasn't been asked yet is how does the board deal with compensation? That's obviously the third rail that has electrocuted so many boards and executives on how to continuously pick open the scab of the compensation strategies. But on the clinical, it's a good question. I think you said Jed raised. I also think that great boards and high-performing boards and the larger boards are involving not just the physicians, but the other allied health professionals and other clinical staff in those clinical discussions. So that's important to keep in mind as well. Roger, anything about how you've seen better attention on the clinical focus?
No, I think you covered that pretty well, although I think the quality committee, what I've been struck by over the last few years is when you get the lay members of the board involved with quality and they start to understand all the various issues, they're very, very effective in influencing movement on some of the things that are critically important to achieve the goals of the quality indicators.
Thank you. We only have perhaps time for one more question, and then I think it would be wise to give an opportunity for a closing comment to Ryan and a closing comment to Roger as well as myself. Is there, can we take at least one more question? I know you have several.
Yes, we'll take one more, Jim, and then as a reminder to our participants, if your question does not get answered, we will follow up with you following the webinar and make sure to get it answered for you. The final question I'll take asks about how to engage and executive leadership with physician governance and priorities at group level, and conversely, how to achieve quote-unquote obedience or engagement with system strategies with which medical group physicians and governments may not agree or is their best interest.
Wow, that's complicated. That's a tough one for the one at the end. One observation that must undergird the answer to that very important and wise question is trust. If the physician shareholders do not trust who serves on the board, they will always be second-guessing and always prone to not comply with the policies that come out of the board deliberations. Similarly, the board does not truly respect its colleagues on the board, whether they are physician members of the board or non-physician board members. If they have cumbersome decision-making processes, if they feel like they're not getting true factual evidence upon which to make their decisions, if they think management isn't giving them information in a timely enough way for them to draw on that knowledge to make more informed decisions, you're going to run into continuing challenges. The last observation I would say in terms of how does the board work to do its strategic planning, to reach a consensus on the policies that will guide the organization going forward, I think it's always good to base these discussions on what is good for the patient. I think it is useful at least once a year to have a conversation at the board level about what is our strategic vision for the group. What do we want to look like and behave like in the summer of the year 2020? What do we think are the obstacles that are likely to get in the way of us achieving that desired future state, that vision? And what are a handful of actions and investments we're going to have to take in order to improve the probability that we can, in fact, embrace and achieve that vision? If we can keep the conversations at the board level focused on the strategic vision and look at removing barriers and enhancing actions and investments to get there, that helps increase the quality and also, curiously enough, the efficiency of decision-making at the regular board meetings. We probably could spend a whole webinar on that one question, so thank you for whoever teed that up. I wish we had more time to drill into that in more depth. I see from notes that Vicki's passing me, there are several more questions. I'm sorry we can't get to them right at the moment, but we will be sending out to the participants here the questions and the answers so that you all get them. I will also mention that we'll send you copies of the slides and the two documents that we cited at the beginning of this webinar. Vicki, are there some logistic comments that you would like to make before we get a closing observation from Ryan or Roger?
You know, just a few to wrap up. On the screen now you can see contact information our speakers for Jim and also Dr. Roger Gilbertson. If you have any further questions that you didn't get to ask today or that you didn't already submit, you can contact them to have a discussion at a later time. And then also following today's webinar, as already mentioned, all registrants will receive a copy of the survey report and the resource medical group governance 50 practices of top performing boards. In just a few days following this webinar, a recording of it will be available both on the AMGA website at amga.org, and it will also be available on the Integrated Healthcare Strategies website at ihstrategies.com in our Knowledge Center, so you'll want to navigate there.
Thank you. Ryan, would you like to make a closing comment, and then I'll turn to Roger, and we will then be adjourned.
No, I'd just like to thank all of our attendees for joining us for today's webinar, and to thank you, Jim and Roger, for your insights. It certainly was useful, and you can see by the large number of attendees what a hot item this is for our members. So we appreciate you all being our resources and for everyone joining us today.
Thank you for facilitating this and making it happen, Ryan. Roger, a closing comment?
Yeah, just it was a pleasure to be on this webinar this afternoon, and my final observation is there's a lot of good information on governance, but I think that at the end of the day, there has to be significant physician involvement at the governance level as well if we're going to be successful. So don't give up on physicians, even though sometimes they may sound disruptive when they first come on the governance in the governance role. But I can tell you by my experience, and I feared that as well, The reason they're disruptive is because they don't understand. And so when they come on after they've had leadership and training and understanding the governance, they are extremely beneficial in the governance role. So that's the precursor that has to happen before you're going to get effective governance.
I think you're right, Roger. Let's close with the observation that this nation needs high-performing medical groups. High-performing medical groups need high-performing boards, and high-performing boards need those enlightened and engaged and empowered physician leaders that Roger just referenced. Thank you all for participation. We will bring the webinar to a close.